everyone, and welcome to. Okay, got it. Welcome all. Gecko is hosted by the Gastro Foundation in association with the Project Echo, University of New Mexico. Uh, Gecko Fellows is run every second Monday at 6 o'clock, but lately we've been running it every Monday to make up for a few sessions that were missed. If you have any questions, you can put them into the chat over there. Thanks. So our presenter this evening is Jessica Wynn, and she'll be speaking to us on diverticular disease. So I'll hand over to Dr. Wing. You want to start your screen sharing and get stuck into it?
Yes.
Jessica, thanks.
Okay. Let me just move this out the way quickly. All right. Okay, can everyone hear me well?
Yes, we can hear you and see your PowerPoint.
Okay, awesome. Okay, so good evening, everybody. I'm Jessica Wing. I'm a gastroenterology medical fellow at Charlotte Maxeke Johannesburg Academic Hospital, as well as at Wits Donald Gordon Medical Center. And tonight I'm going to be speaking to you about the very common and the bread and butter topic for all gastroenterologists, colonic diverticular disease. And although this is a very common disease, we still actually have limited knowledge and evidence on its pathogenesis, as well as medical therapy. So this disease is still largely evasive to us. Okay, looking at the outline of my presentation, we're going to go through definitions and terminology just to get things out the way. Then epidemiology locally and internationally, looking at pathology, pathogenesis, and then the clinical spectrum of diverticular disease. So that would be symptomatic and uncomplicated diverticular disease, or SCAD, diverticulitis and its complications, a diverticular bleed, and then segmental colitis associated with diverticulosis. And then lastly, we'll just look at a key take-home messages. Okay, so now looking at our definitions and on terminology, a diverticulum or diverticulosis, plural, is an anatomic change in the colon wall characterized by outpouchings of mucosa and submucosa through the muscularis. Diverticulosis is the presence of diverticular, so plural, regardless of any symptom. In diverticular disease is if you have clinically relevant and symptomatic diverticulosis. And these are under the following four pillars. So symptomatic uncomplicated diverticular disease, or SUD, acute, chronic, or recurrent diverticulitis. And there's also now another term called Smouldering diverticulitis, which we'll speak about. Then segmental colitis associated with diverticulosis, or SCAD. And then lastly, diverticular hemorrhage. Okay, so looking at our epidemiology, prevalence of diverticulosis is largely age-dependent. So the older you are, the more likely you are to have diverticulosis. In the USA, which has one of the larger databases, prevalence of diverticulosis increases from fewer than 20% at the age of 40 to 60% by the age of 60. In Western countries, there's left-sided predominant disease, so 90% will have left-sided predominant diverticulitis, villosis. And in those African Americans, however, are more likely to have proximal disease, so more proximal more on the right side. In Asia, 75 to 90% of patients have right-sided diverticulosis. And in South Africa, and this was actually from a review article from Dr. Naidoo back in 2009, diverticulosis in Black South Africans was largely predominantly found in the descending colon, and that may reflect urbanization, adoption of the Western lifestyle. Then moving on to the prevalence worldwide, it has increased in the West and in countries that have adopted the Western lifestyle. In Africa, there was a systematic review done of around 30 studies. This was published now in 2024. It noted a threefold increase in the prevalence of colonic diverticulosis in a 10-year period from 2012 to 2022. Most common in males that were over the age of 50 and in the left colon. So again, reflecting the westernized lifestyle and urbanization. Risk factors, proven ones are male, if you're Caucasian, smoking, and increased body mass index. And low fiber diet and constipation were actually not shown to increase risk of diverticulosis, despite its classic appeal. And then sedentary lifestyle, alcohol, as well as red meat consumption did also not increase the risk of diverticulosis on colonoscopy. Okay, so getting to some of the pathology, just to be clear, a true diverticulum contains all layers of the bowel wall. So a mecal diverticulum is an example. And then a pseudo diverticulum, which is what I'm speaking about, so colonic diverticuli, are pseudo in a way that these herniations are just of mucosa and submucosa, and it excludes the muscle layer, and it actually herniates through the muscle layer of the colon. So it's not a true diverticulum. They originate in a they're not random, despite what we think when we're doing the colonoscopy. They don't originate in random areas. They originate in 4 distinct rows, which correspond with the penetration of the vasorector vessels and of a fixed position in relationship to the tinea coli. I'll show you in the next diagram. So the usual size is around 3 to 10 millimeters, but there are giant diverticular, and those can range from 4 to 25 centimeters. And those are important because they have an increased risk for complications, more than 30%. This is what I was speaking about in terms of where they originate from. So these are your tinea, your mesenteric tinea and your anti-mesenteric tinea. You'll get diverticular at either side of the mesenteric tinea, and then on the mesenteric side of the anti-mesenteric tinea. So in these 4 areas here, this is where they will originate from. And they're entering, it's where they enter into the circular muscle. Okay, then looking at the pathogenesis, there are 4 key pillars. The first pillar is heritable factors, colonic wall structure, motility, and then environmental factors. So let's start off with the colonic wall structure. Sorry, I just want to move this out of my way. Sorry. Okay, so colonic wall structure, the longitudinal and circular muscle fibers are both significantly thickened. This gives a mycotic or mycosis-like appearance, which is like an accordion, and in Greek it means heaped up muscle. So it increases in elastin, there's an increase in elastin deposition within the wall of the colon, and a shortening of this tinea and bunching up of the circular muscular layer, like an accordion again. What they have noted histologically is that there is an increase in type 3 collagen synthesis, and upregulation of inhibition of metalloproteinases, so those enzymes that break down all collagen. So this is seen with age-related changes in collagen composition, and that's why there is, with increasing age, a higher prevalence of diverticulosis. Then, from what we know, connective tissue integrity is very important because there's a higher rate of diverticulosis in connective tissue diseases such as Ehlers-Danlos, Marfan, systemic sclerosis, and even autosomal dominant polycystic kidney disease. Then looking at colonic motility. So based on manometric studies of the sigmoid colon, there are 2 main mechanisms for abnormal motility. The first is that there's higher resting, postprandial, and neostigmine stimulated luminal pressures in the colon. And these pressures also are propelled in a retrograde fashion, so they have an abnormal direction. There is a theory of segmentation, which was coined by Dr. Paint, which is contraction of the colon at the Horstall folds occurs in small segments, like tiny little bladders, rather than a continuous tube, resulting in very high or excessively high pressures in each segment. Then histologically, if you look at the colonic mucosa, the iron transport is the same in controls versus diverticular patients. The number of myenteric and submucosal plexi are also the same. However, the only difference they seem to see is that there's a decrease in the number of the interstitial cells of Kagel, or your pacemaker cells. And then another important mechanism is increased tonicity. There's an imbalance in your excitatory cholinergic neurons and your decrease in your non-cholinergic, non-erginergic inhibitory neurons. So there's increased tonicity, increased luminal pressure, and an abnormal direction. That's what you need to take away from the slide. Okay. So then looking at environmental factors, and we're mostly going to be discussing fiber here because that's the most important one. Historically, diverticulosis was labeled as a deficiency disease of fiber. This is because they thought that there were slower transit times in diverticulosis with in a low fiber diet, which means increased luminal pressure and increased diverticular herniation. A low fiber diet would also decrease your stool size and volume. Excuse me. Then looking at association between dietary fiber and diverticulosis, the evidence is actually quite unclear. And the AGA has come to say, this is from the 2020 guidelines, that but it was in the context of acute diverticulitis, that there's very low quality evidence, but there's an unconditional recommendation because there's an unlikely risk to patients with a potential benefit. Then looking at environmental factors beyond dietary fiber, these are just some of the risk factors that have associations with diverticulosis, but aren't causal. Okay. Then looking at hereditary factors, looking at sex first, in terms of developing diverticulosis and diverticular bleeding, women and men have the same risk. But in terms of having attacks of acute diverticulitis, women experience higher risk than men. Then looking at genetics, a Danish study did show that diverticulosis and its complications strongly aggregate in families. And a Swedish twin study did report that there is a genetic component of around 40% in diverticulosis. And this is largely related to the T cell receptor gene, TNF-SF15, that has been implicated in diverticulitis, and that actually requires surgery. So those patients that require surgery, they have this gene in common. Excuse me, I'm just recovering from a bit of a cough. Then lastly, in terms of ethnicity, epidemiological studies show that African Americans have the highest prevalence of diverticular bleeds, and that surgery for diverticulitis is more common in this ethnicity group. I don't know if that is because of late presentation and that's more surgery needed, or if it's a true representation. And then Caucasians have the highest prevalence for diverticulitis. This is a very important slide. It's a summary of your clinical spectrum of diverticulum disease. So we have diverticulosis. Most people, 85%, are asymptomatic. Then the other 15% are symptomatic. And under that pillar, like I've said before, there's SCAD, diverticulitis, diverticular hemorrhage, and SCAD. And then diverticulitis can further be divided into complicated and uncomplicated diverticulitis. Complicated diverticulitis requires an abscess formation, fistula formation, obstruction, or free perforation, which we'll discuss all later. So moving on to our first clinical manifestation, which is SCAD. It's non-specific abdominal complaints in a patient who has diverticulosis without any complications. So it's someone who has incidentally diverticular disease on their screening C-scope and now complains of non-specific abdominal complaints. Its true prevalence is unknown because it's largely, most of the trials are done in diverticulitis, and there's a difficulty in distinguishing this entity from IBS. Some people say that they have a shared pathogenesis. There's a benign course. It's a very low incidence of complications. And this was shown in a prospective study that was carried out over 11 years in 119 patients with SCAD. 97% of them had no or very few symptoms. Only 1.7% developed acute diverticulitis, and then 0.8% required surgery for chronic ongoing symptoms. Then this is just a mind map. I thought that would be nice to use later when you're studying. So looking at the pathophysiology, is there shared pathophysiology with IBS, or is it a late consequence of IBS and prolonged dysmotility? So the key pathogenesis there would be visceral hypersensitivity, chronic inflammation, colonic motility, and altered intestinal microbiota. And then looking at your clinical features, it's mainly left lower quadrant plane, because remember, it's mainly left side predominant. It's relieved by defecation or passage of flatus. And like IBS, there's passage of mucus and change in bowel habits, so bloating, diarrhea, and constipation. So a large overlap with IBS. Then looking at investigations, colonoscopy. We'll have a slide on this later, explaining about the risk of colonoscopy in diverticular disease. Then your next investigation of choice would be your CT abdomen or CT colonography. A barren enema is no longer really needed unless the patient is unable to undergo either CT abdomen or colonography or colonoscopy. Your labs will normally be normal. However, you will have a higher fecal calprotectin in controls than in IBS patients. So there is an element, a very small element of subtle inflammation. So this was shown in a small case controlled study. So in terms of treatment, like I said, there is this debate about soluble fiber. Remember, insoluble fibers like bran can actually worsen your symptoms. So it must be soluble fiber, so a psyllium husk. It's still recommended in the treatment guidelines, but like I said, no clear evidence on its clear benefit, but there's no harm. Then because I said that there is a subtle underlying inflammation, there is this rationale for using 5-ASA, but that the studies for that haven't become very promising over that. The DIVA study was done, which was essentially a study looking at acute diverticulitis and the use of mesalazine of 2.4 grams over a 3-month period. And then in 1 year, they had less GIT symptoms, but that's in the context of diverticulitis. So you can't really extrapolate that to SUD. Then because there's this intestinal microbiome dysregulation, rifaximin has been tried, also no real promising results. Probiotics are also no clear evidence on probiotics, but some do advocate for it because of the altered intestinal microbiota. And then just symptomatic treatment, so anticholinergics, antispasmodics. And in surgery, there's no clear role unless you've got these ongoing recurrent symptoms that are affecting your quality of life. Okay, so look, just a word on colonoscopy. Does colonoscopy increase the risk of perforation in diverticular disease? So no, in uncomplicated diverticular disease or diverticulosis, it has no impact on perforation. So the burst pressures or the pressures needed to burst a diverticulum far exceed the standard insufflation pressures using colonoscopy. Even if you're pressed against the wall or if you're using high insufflation pressures, you're still safe. So you can use it to evaluate symptoms in a patient known with diverticulosis. It becomes very challenging. I'm sure all of the fellows can agree that they've had an elderly patient with extensive diverticular disease, and it's very challenging. This is because of that luminal narrowing, that mycosis, that thickened muscle, the spasm and fixation from prior inflammation, as well as confusion between the diverticular openings and the lumen itself. So how can you overcome these difficulties? You can use a pediatric colonoscope. You can do sigmoid flotation maneuver because that's the most difficult part. So that's just instilling 100 mils to 300 mils of water, or you can use water-assisted colonoscopy, so using water the whole way until you get to the cecum. Just a word to be cautious with air insufflation and force when advancing. Okay, so now we're getting to the big topic of diverticulitis. This is one of the more important topics. So the definition is inflammation and or infection of a diverticulum. Its incidence is about 1 to 4% in that symptomatic group over a 7-year follow-up period. So looking at the USA's National Inpatient System Data Service, which is the largest data of all the inpatients in their country, it's a central database. The prevalence has increased and plateaued plateaued from around 2008. And the severity of disease has also decreased, and surgery has also declined from 25% in that time to 15%. And remember, you get acute, chronic, recurrent, and smoldering diverticulitis, which I'll speak about. And then the absence or presence of obstruction, an abscess, a fistula, or a free perforation delineates the difference between uncomplicated and complicated diverticulitis. Smoldering diverticulitis is basically diverticular inflammation that persists for weeks or months. It has a more subacute course. So looking at our mind map of diverticulitis, its pathophysiology is you get obstruction at the neck of the diverticulum with a fecalith, as in the picture I showed you earlier on, and you get small mucosal abrasions in the diverticulum, causing microperforations and low-grade inflammation. Because of the edema from the inflammation, you get decreased venous outflow and increase in normal bacterial flora in that pocket, then localized ischemia and altered mucosal defense mechanisms, specifically at CD2 pathway, if you want to read more about that. And then there is this thought that there is CMV reactivation. So in most of the specimens that they found for acute diverticulitis had CMV reactivation. Okay, clinical features will be similar to SUD, so you'll get left lower quadrant abdominal pain unless you have an Asian or elderly patient, you'll look more right pain. You can also present with diarrhea, altered bowel habits, constipation, anorexia, nausea and vomiting. It's less likely, but can occur. And it's one of the things you can actually differentiate between recurrent diverticulitis and appendicitis. So vomiting and nausea more in appendicitis, and then more of the diarrhea and constipation in the diverticulitis. So fever as well. Peritoneal signs may be present, but shock is very rare. And that's when you suspected perforation, free perforation, and peritonitis. And sometimes you can feel a palpable tender mass on exam, and that's if an abscess or a phlegmon has formed. Investigations you'll go to here would be your CT abdomen. You must give oral contrast, IV contrast, and if you can, an enema of contrast. That'll give you the best information. And you'll see fatty stranding, pericolic fluid. Sometimes you'll see air bubbles within the wall of the colon. And sometimes you can see the complications, so abscesses, fistula formation, and then free perforation. If this patient is unable to tolerate a CT abdomen, you can offer, in terms of if they've got renal dysfunction or any other contraindications, you can order a barium enema, which is water soluble because you don't want to cause peritonitis. Always do a plain abdominal X-ray to exclude perforation. Ultrasounds have a very similar sensitivity to CT abdomen, but just remember they're very operator dependent, and that CT abdomen is still the gold standard. You suspect diverticulitis more if your CRP is more than 50. So not like SCAD, where you have normal laboratories, your CRP here will be raised more than 50, and you will get a leukocytosis with a left shift. And then colonoscopy should be avoided in this acute situation, and you can limit this to a sigmoidoscopy. In terms of treatment, there's actually 70 to 100% success rates with non-surgical measures. So whether it's you're an inpatient or outpatient, conservative management seems to be successful in most of the cases. And that's bowel rest, a liquid diet, and then this controversy about antibiotics in complicated and uncomplicated diverticulitis with anaerobic gram-negative bacilli cover. Interventional radiology has come to the fore in these last years, which I'll speak about a bit later, and then surgery. Okay, so looking at your inpatient criteria for uncomplicated diverticulitis. So all of your complicated diverticulitis patients, so those that have perforation, abscess formation, fistula, obstruction will be admitted. And then those that don't have any of those complications but still have acute diverticulitis, you'll need one or more of these criteria to admit them. Otherwise, you can treat them as an outpatient. So if your temperature is more than 38 or less than 36 degrees, your pulse is more than 90, respiratory rate more than 20, white cell count more than 12 or less than 4, CRP more than 15. So all of the sort of SOFA-like criteria or organ dysfunction criteria for sepsis. Then looking at severe abdominal pain with failure to control abdominal pain in the emergency department and a score of less than 5 on your visual analog scale, which I don't think we have access to in our emergency department. If you're an elderly patient with significant comorbidities, if you're immune suppressed, especially your solid organ transplant recipients, if there's intolerance of oral insects, so you can't take oral antibiotics or any oral fluids because you've got a bowel obstruction or an ileus, you would admit that patient. Unreliability, so if your patient's not going to return for visits, because we actually like to see them sooner rather than later after acute diverticular attack, or if they lack a support system, then you would admit them, and if they fail their outpatient treatments. Okay, so what are the inpatient measures? So your general measures will be analgesia, largely parenteral if they can't tolerate oral feeds, and just to avoid your NSAIDs because they increase your risk for diverticular bleeding. So morphine, Pathology can be used. Then some prefer complete bowel rest, so nil per us until you can tolerate a clear liquid diet. Others, there's no clear consensus. Some authorities say that you can start with a clear liquid diet. So it's all context and patient dependent. Then looking at your IV fluids, you give IV fluids until you're tolerating oral liquids, and then IVI antibiotics that cover both gram-negative bacilli and anaerobic cover. So for uncomplicated diverticulitis, they're usually very small hospital admissions, like 2 to 3 days, and their diets can be advanced by then if they're tolerating an IVI antibiotic stopped, and they can be given a course of oral antibiotics to complete for 10 to 14 days. But all these criteria must be met before they discharge. So normalization of their vital signs, resolution of severe abdominal pain, resolution of a significant leukocytosis, tolerance of an oral diet, and resumption of their normal bowel movements. If you fail to improve in 2 to 3 days of IVI antibiotics, you need to repeat your imaging, so namely your CT abdomen, to identify if there's a new complication. Has an abscess formed? Is there perforation? Is there obstruction? And then surgical evaluation is indicated at any point during that admission if the patient condition deteriorates. Okay, this is just a quick slide to show what you would choose for your IVI antibiotic choices. So if you have a low-risk community-acquired infection, so that means that you're not elderly, you don't have any comorbidities, you're a young patient, you would go for metronidazole plus a cephalosporin or fluoroquinolone. If you're high-risk community-acquired, so if you're a transplant patient, other forms of immune suppression, elderly with multiple comorbidities, or exposed, say you're a healthcare worker, which use a carbapenem, tazocin, and then once again, a third generation cephalosporin and metronidazole. If you are, say, an ICU patient and you develop acute diverticulitis while admitted, then you would go for carbapenem, tazocin, plus your cephalosporin and your metronidazole, and then add on your ampicillin and vancomycin. So we're essentially covering Enterobacteriaceae, streptococci, and Pseudomonas in these two groups. And then over here, we also cover your MRSAs, and then we can add antifungal cover as well in the last group. So if you want to read, I just added extra slides. If you want to go back and look at the exact regimens, this is for your low risk. This will be for your high risk patients. And then this will be for your hospital acquired patients. All right. So now looking at complicated diverticulitis, which are four main groups. So your first group is obstruction. So this is because there's inflammation intrinsically from an abscess outside, or because of the edema itself and inflammation causing luminal obstruction. Small bowel obstruction can occur when a loop of your small bowel gets caught in that inflammatory mass and mesentery around the diverticulitis. And then complete obstruction is unusual, unless it's from stricturing from recurrent episodes of diverticulitis, so chronic disease. You can offer them endoscopic dilatation and a self-expanding metal stent, but usually surgery would be the answer. Bowel rest and an NGT suction from a medical point of view, antibiotics, and they're not improving for surgery. Okay, and then looking at your abscess formation, you'd, sorry, this is in my way. 15% of patients with your diverticulitis will develop an abscess. There's a tender mass, which is usually, you can feel on clinical exam, persistent leukocytosis and fever despite an adequate trial of antibiotics. Your investigation of choice would be a CT abdomen. We do something called the Hinchey classification, which ranges from 1 to 4. If you want to read further on that, I didn't have a slide on that. If your abscess is less than 3 to 4 centimeters, it usually can be resolved just with IVI antibiotics alone. And then you can use interventional radiology for CT-guided percutaneous, transrectal or transvaginal drainage. And then elective open or laparoscopic surgery at the end. And then looking at free perforation, this is the worst of the complications. So free fecal peritonitis by free perforation is very uncommon, 4 per 100,000 cases. Mortality is about 12 to 26%. And you'd go for plain X-ray showing free air, and the clinical diagnosis, a clinical diagnosis or CT will make the diagnosis fairly quickly. It's a surgical emergency, and surgery is usually done in 2 stages because of the contamination. You don't have time for bowel preparation. So it'd be a resection and then a colostomy. And then your fistulas, your abscess ruptures, when your abscess starts to rupture into adjacent organ, that causes a fistula. It's around 5% of patients with diverticulitis, but present in about 20% of those that require surgery. The most common, I think we need to know, is the colovesicular one, about 65%, and it's more common in males than females, mainly because the females are protected by the uterus. It'll present with pathognomonic fecal urea, pneumaturia, and multiple UTIs. You can do a cystoscopy, a cystography, or barium enema, as well as a CT. And then your next most common fistula is your colovaginal fistula, around 25%. It's a single-stage surgery. You do a single-stage surgery for these fistulas with the repair of the fistula and primary anastomosis, but there's still an 8% mortality. And then your intracutaneous and your colocutaneous, and then your colourethral, coluterine are also other fistulas that can form, but are quite rare. Then looking at outpatient management for uncomplicated diverticulosis, your outpatient management has a high success rate, about 94 to 97%. Like I said, you give your analgesia, you stop your NSAIDs as soon as your acute episode is resolved, as chronic use is associated with diverticular complications, namely a bleed. You use your bowel rest and liquid diet for around a week until they can tolerate fluids. Then, like the AGA said, there's selective antibiotic use. So if you're immune compromised, if you have severe comorbidities, if you've got a severe inflammatory response, then you can choose to use antibiotics. Otherwise, you don't have to give antibiotics for uncomplicated outpatient management of diverticulosis. So it's a case-by-case individualized decision. It's not mandatory. You can choose not to give antibiotics, but if they are immune compromised, they've got a severe inflammatory response, they've got comorbidities, then you would give them a course of 10 to 14 days. And these were based on the Diabolo, which is a Dutch trial, and the Avid trial, which is a Swedish trial, with 1,100 patients as their population sample. And antibiotics did not accelerate recovery and did not prevent complications or recurrence in acute uncomplicated diverticulitis. And then the downward trial used augmentin, amoxicillin clavulanic acid. It also had similarly low rates of unscheduled return visits. So antibiotics didn't really have a role in any good outcomes in uncomplicated diverticulitis. However, you can make that decision based on the patient in front of you if you'd like to use antibiotics. Okay, this is a small table just showing you regimens for the antibiotics you can use as an outpatient: augmentin, ciprofloxacin, levofloxacin, and then plus your anaerobic cover with metronidazole or flagyl. And then as an outpatient, once you've discharged them, they've completed the antibiotics, given them bowel rest, given them fluids, rehydrated them. You'll see them within a week of the initial presentation. If they improve, you don't need to repeat the imaging studies, and you monitor them for recurrence of symptoms. And then I'll discuss about undergoing colonoscopy electively in 6 to 8 weeks after your first diverticulitis event, if they haven't done so within the previous year. So patients that do not improve, you need to admit them for inpatient treatment, as we discussed, repeat the CT to see if there's a new complication that is formed. And then you can also consider smouldering diverticulitis or another diagnosis completely. So is this just IBS or IBD? Smouldering diverticulitis is subacute but protracted. So it's, again, left lower quadrant where your sigmoid is, alteration in bowel habits, some rectal bleeding, and it's often after cessation of the antibiotic trial. It's chronic, it can last longer than 6 months. You must differentiate it from recurrent diverticulitis and other conditions such as irritable bowel syndrome. The key feature here is to remember there has to be colonic inflammation. So the repeat CT scan, you'll see thickening, pericolic fluid, stranding. On low endoscopy, you can see some features of colitis, and your fecal calprotectin will be raised. These patients should be referred to surgical evaluation. There's not much room for medical therapy here other than trialing your fiber as well as your analgesia, rehydrating them, and that trial of antibiotics. So a systematic review did show that elective surgery reduced recurrence in patients with complicated, which we know, disease, smouldering disease, and then frequently recurrent diverticulitis. Then looking at recurrent diverticulitis, it's about 42% of the patients that have diverticulitis will have more than one recurrent episode after non-operative management. And it's not usually more severe than the initial episode. There's no evidence for surgery for recurrent episodes of uncomplicated diverticulitis. Historically, the literature used to say after 2 episodes of diverticulitis, which was uncomplicated, they would advocate for elective resection, but that's no longer the rule. It's important, however, to remember that the distal level of resection must extend to the rectum. If they don't extend to the rectum and they just do a colosigmoid anastomosis, it doesn't extend further onto the rectum, it results as a 4-fold increase in recurrence of diverticulitis than those that had a colorectal anastomosis. So this is what I was talking about with the elective colonoscopy after diverticulitis. So the reason why we're doing it is to exclude a concomitant colonic cancer, because diverticulitis can also mimic colonic cancer. So in 2 meta-analysis, colorectal cancer was detected by colonoscopy in 8.3 to 10% of patients with complicated diverticulitis. So it goes without saying that those patients will get a repeat elective C-scope 6 to 8 weeks after their admission. But in uncomplicated diverticulitis, only 0.5 to 7% of those will develop CRC. So the Americans are in favor of routine colonoscopy after uncomplicated diverticulitis, but the European experts are against it. Looking at the American Surgical Colorectal Society of Colorectal Surgeons in 2020, they advocate for the colonoscopy after all complicated diverticulitis and after uncomplicated diverticulitis that had imaging abnormalities or an atypical course of their disease. I think in our setting, we need to base this on resources. We can't do colonoscopies for every uncomplicated diverticular disease we get. We have to look at our patient comorbidities and the clinical course and individualize our colonoscopies. And then looking at the role of elective surgery. So like I said, usually it's 2-staged. It's colonic resection and then a colostomy with a review to have to take down the colostomy. And then there is an ongoing dialogue, however, regarding resection and primary anastomosis, or one-stage procedure. So the role of elective surgery is mainly in high-risk patients of developing serious complications or dying from recurrent diverticulitis. So those patients would be those that have complicated diverticulitis, such as a fistula, obstruction, free perforation. The one complication that there isn't clarity about is if you've had a healed diverticular abscess. They say that you don't need elective surgery after that, and some say you do. So it's based on symptoms and quality of life and your own institution's thinking. And then if you're immune suppressed and you have uncomplicated diverticulitis, that would also be a role for elective surgery after your initial episode. So it's not offered to immune competent patients with a history of uncomplicated diverticulitis, regardless of the number of your past episodes. So other outpatient measures, healthy lifestyle, you can recommend a high fiber diet just because there's no harm and there is potential benefit. Just importantly, do not counsel on avoiding nuts, seeds, and corn. There was actually a large study of 47,000 people, which actually showed an inverse relationship to developing diverticular and eating popcorn, nuts, and seeds. And there's no implication on complications of diverticulosis and diverticulitis by eating nuts and popcorns and seeds. Do stop your NSAIDs as well as aspirin unless they are for cardiovascular reasons, as it is associated with diverticulitis and increase in diverticular bleeding. Mesalamine. So a Cochrane systemic review and a meta-analysis of about 7 randomized trials found no evidence of an effect when comparing mesalazine with control for prevention of recurrent diverticulitis. So not much evidence for mesalamine there. And then there's poor evidence for rifaximin use. And then looking just at some special populations. So it's the youth, which is defined as less than 40. It's relatively uncommon. About 10% of patients with diverticulitis, they're often misdiagnosed or as IBD or IBS. It's also common in the sigmoid colon and more predominant in males. Youth is an independent risk factor for poor outcome when you have acute diverticulitis, and it's managed non-operatively. They have initial attacks are more severe than elderly patients. They have a complication recurrence rates that are much higher as well than the elderly. So this prompted a rationale for elective segmental colonic resection after one attack historically, but in a large series, they found that higher rates of surgery in young patients was primarily due to prevent poor outcomes rather than having higher complication rates itself. So it was a more preventative measure rather than actually seeing those complications itself. Then once again, the American Society of the Colorectal Surgeons say that we do not offer elective surgery to patients who have a history of diverticulitis simply because they are young, just to keep that in mind. Then looking at immune suppressed patients, it manifests very subtly, can be a challenging diagnosis to make. It's not more common than other groups, but it confers a more severe consequence than the immune competent patient. They have a higher rate of free perforation, higher need for surgery, and a higher post-operative mortality. Solid organ transplant recipients particularly have a very high mortality risk, around 25% to 100%. So many authorities would advocate for elective resection after their initial episode of acute diverticulitis, whether it's complicated or uncomplicated. Looking at right-sided disease, so predominant in Asia, like I said, compared to the West, which is only 1.5% in the West, it's indistinguishable from acute appendicitis. So if they're older, they're Asian, they have less frequent nausea and vomiting, a lack of progression of symptoms such as appendicitis, you must consider right-sided diverticulitis. Radiologically, it's also very difficult to differentiate between acute appendicitis and right-sided diverticulosis. And the diagnosis is often made laparoscopically or on open surgery. They are less likely to develop complications than left-sided disease, and medical management is usually sufficient, and the treatment is the same for left-sided disease. Okay, quickly a word on SCAD. So as an introduction, it was thought to be a rare form of Crohn's disease in the segment of colon which contains the diverticulae. However, it's now clear that it's a distinct but very rare, poorly understood manifestation of diverticular disease in a very small subset of patients. It's characterized by chronic mucosal inflammation and colonic segments which have those diverticulae. So the rest of the colon is normal. It's just in those interdiverticular mucosal sections where you have chronic mucosal inflammation. Most of them are male patients. The mean age is around 63. It mimics the presentation of IBD, whereas SAD mimicked the presentation of IBS. So it primarily affects the sigmoid colon, and it does not confer a higher risk of diverticulitis or CRC. Pathogenesis is unclear. They think that the prolapsed mucosa causes chronic mucosal inflammation by being exposed to shear stress. There's changes in your bacterial flora, bacterial enzyme activity from fecal stasis, and there's increasing permeability to your intraluminal antigens or altered microcirculation leading to focal ischemia. Our mind map again, these are the differentials you need to consider, which you've seen often: acute diverticulitis, ischemic colitis, drug-related colitis, IBD, solitary rectal ulcer syndrome, infectious colitis, and radiation colitis. However, these all have subtleties where it's easy to differentiate between them. Okay, the clinical presentation: left lower cramping pain, chronic diarrhea again, rectal bleeding, mimics IBD. You'll choose a CT abdomen as your investigation of choice. There's thickening in the segments of the colon with pre-existing diverticular and pericolic fat stranding. Your white cell count is usually normal, which differentiates you from your acute diverticulitis, but your fecal calprotectin and lactoferrin will be raised. And then I'll show you a quick slide on the classification of types A, B, C, and D. In terms of histology, you'll see cryptitis and crypt abscesses and chronic lymphocytic infiltration and even granulomas, so very similar to IBD. Then your course is poorly understood. It's benign and usually self-limiting clinical course, but endoscopically over time, it seems to evolve into a ulcerative proctosigmoiditis picture or a Crohn's colitis picture. So if there is ongoing symptoms, it must prompt early endoscopic reevaluation because it's usually self-limiting. So if they've got ongoing progressive symptoms, you need to repeat their scope pretty early. Then looking at their treatment, it's not well defined. It's based on case reports. So you'll trial ciprofloxacin and metronidazole for 10 to 14 days. If that doesn't work, you'll start them on a 5-ASA regimen. So mesalazine, usually 800 milligrams for 7 to 10 days. You increase the dose to 1.6 if there's no response. And then if that's not helping, you choose prednisone for about a week and try wean them slowly over 6 weeks. And then if that doesn't work, there is this query immune therapy and biologics, but it hasn't been trialed yet. And then you'd go to surgery for steroid refractory or dependent disease. Okay, so this is just a picture. This would be type A, which I'll explain quickly later, which is just on the fold of the mucosa here, where you see the inflammation. It's interdiverticular mucosal erythema, friability, and erosions that are noted in varying degrees. The inflammation doesn't extend into the diverticular orifices, which is important and differentiates from diverticulitis. And the inflammation is only found within the segments of colon that have the diverticulae. The inflammation is usually limited to the intradiverticular mucosa of the sigmoid. It's usually only in the sigmoid. And the remaining colon and rectum is neither endoscopically or histologically involved. This is just a quick classification. So type A, B, C, and D. A is just on the fold. B represents a mild to moderate ulcerative colitis-like pattern. C is Crohn's pattern, and D is a severe ulcerative colitis pattern. I think these are all we need to really know. Crohn's-like, severe ulcerative colitis, mild to moderate, and then concentric fold pattern. Okay, into our last manifestation, which is diverticular hemorrhage. It's the most common cause of a significant lower GIT bleed in adults, around 1/3 to 2/3. And then bleeding is estimated to occur in around 10 to 15% of patients with diverticulosis. And of those, 3 to 5% will have severe hemorrhaging. So the culprit diverticulum is usually not identified. It's often a presumptive diagnosis in the context of someone who has diverticulosis with no other source identified. Pancolonic diverticulosis has the highest hemorrhage rate rather than segmental disease. And then your diverticular hemorrhage tends to arise from the right colon more than the left. So that's one thing that is different. Everything else has mainly been left-sided, but in bleeding, it's usually on the right. In pathophysiology, again, poorly understood, you get intimal thickening and medial thinning of your vasorecta, causing your weak vessels. And if you can imagine, as the diverticulate starts herniating, the vasorecta are stretched over the apex of the diverticulum with a thin layer of colonic mucosa separating it from the lumen. So it's stretched, which is increasing its exposure, and it's weak from the medial thinning and the intimal thickening, which together predisposes it to rupture. And then also elderly patients are often on NSAID use, and it's associated with increased bleeding in multiple studies. So this is here, you can see the vessel, how it's been stretched over the apex like this. So it's just mucosa that's separating it from the lumen, increasing its tendency to rupture. And then clinical features, abrupt and painless. Those are two important things. Self-limiting hematochezia. The volume of blood can be moderate to large as the bleeding vessel is an arterial, remember. Patients pass red or maroon clots, but melena is very unusual. And then spontaneous cessation of bleeding occurs in around the majority of patients, 70 to 80% of patients. The 30-day rebleeding rates, so the month rebleeding rates are high, about 53%, and emergency surgery rates are also high, 35%. So the diagnosis, it's classical symptoms and signs. They have a high pre-test probability in an older person, but you must consider other sources, so malignancy, hemorrhoids, telangiectatic lesions, other forms of colitis. If they're hemodynamically stable, you expedite that colonoscopy within 12 to 48 hours of presentation. You look for stigmata of bleeding, so adherent clots, visible vessel within the diverticulum, and you look for active bleeding. And then you only identify the source in around 10 to 20% of colonoscopic examinations. And if you do, you can use these tools, so an epinephrine injection or adrenaline injection, heat probe coagulation or bipolar coagulation, endoclips, a febrin sealant, and then also band ligation you can use for endoscopic control. Okay. If your endoscopic source, which majority of the time is not identified, and the bleeding continues, you can go to your red cell scan or your nuclear scintigraphy, and that detects rates as low as 0.1 mils per minute. It's inexpensive, it's not invasive, and it can identify the site, but not the source of bleeding. So there's no therapeutic potential, which is an issue. And studies have shown a lack of improvement in terms of mortality, transfusion requirements, and the need of surgery. So it's not a great modality in that sense. However, it is a great modality as a gateway to angiography. So it minimizes a negative angiogram because it's already shown you that there is a site which you need to concentrate on. And it helps select a specific artery where they're going to inject contrast into to embolize the specific vessel. So angiography, not as sensitive as nuclear scintigraphy, but also detects very low bleeding rates. They can use super selective embolization, so the exact artery, or you embolize the distal branches. It's becoming the non-surgical treatment of choice when your endoscopic control is not possible. And 67% to 100% of patients actually achieve lasting hemostasis, and your colonic ischemic rates are low at around 20%. So it's a good form of intervention. Surgery, you avoid unless there's endoscopic or angiographic modalities are unavailable or they fail. It's infrequently needed, as I said, because diverticular bleeds resolve spontaneously. So indications would be persistent hemorrhaging, which is refractory and not amenable to therapy, massive transfusion requirements, hemodynamic instability, refractory to resuscitation, partial, and you'd use a partial segmental colectomy, preferred if the bleeding site is identified. However, subtotal colectomy may be needed because you don't know where the site is, so you might have to go in blind and take out the keep the rectum in situ and take the whole colon out. Okay, this is a nice algorithm if you want to refer back to it. So it shows you what you would do in terms of a bleeding patient. It's basically summarizes what I've said. Okay, and those are my references. Any questions?
Oh. Okay,
Sorry.
thanks,
Oh.
Jess. That was quite a comprehensive overview looking at numerous aspects of diverticular disease. So I think we don't have too much of time. So if there's anybody who has a earning question or or wants to make a comment, maybe you can just unmute and go ahead. I certainly don't have anything else to add regarding that. I think it's fairly straightforward. Yes, etiology and pathophysiology of how these things develop. There's some interesting uh, theories out there, and recently I even saw something about sort of a form of IBS occurring after an episode of diverticulitis. So yeah. So I think it's worthwhile just to know a little bit about everything when it comes to diverticular disease, how to handle the bleeding, what's the treatment for diverticular, uncomplicated, complicated diverticulitis, etc., etc. And it isn't too hard, provided you've just read over it.
Can I just ask a question? Good evening.
Hi, Nasif.
Yeah, thanks, Jess, for a very comprehensive presentation. Just in terms of the colonoscopy post episode of diverticulitis, and Jess presented the data in terms of complicated and uncomplicated. Just you see up to 10% for complicated and quite low for uncomplicated. So at my hospital, the surgeons admit these patients, and then they sort of request the colonoscopy from us in GIT afterwards. There's quite a large number of patients that they refer for these colonoscopies, but practically, sort of for these uncomplicated ones, any thoughts as terms of what Jess said about local guidelines? We need to set up our own protocol, but just at other institutions, how do you guys manage this? Do you just do a colo for everybody? If so, how frequently? Thanks.
So I think at our institution, we don't have enough resources to do a elective colonoscopy after every uncomplicated diverticulitis attack. I think we have to individualize that patient's risk. So do we really think there's something else? Is there a malignancy? Are there any other clinical or laboratory features that may suggest IBD or another sort of differential diagnosis? But we don't routinely do a colonoscopy for uncomplicated diverticulitis. I don't know if anyone else wants to add what they do.
Yeah, we also not receive too many requests to do a colonoscopy after an episode of uncomplicated diverticulitis. I suppose if there is a compelling clinical indication, by all means, for sure. Because sometimes you don't know that the patient may be harboring something else. But I think the key thing, and you can add in here, like you just, is there's really no role for a early or urgent colonoscopy in somebody who's got diverticulitis. I think sometimes people there's this it still persists, like if someone comes in with abdominal pain, one of the things people ask for is a colonoscopy, and colonoscopy is not a good investigation. In fact, it might be a relative contraindication for in somebody with abdominal pain, especially if it's severe. The choice, if you're going to do something in somebody with severe abdominal pain and you're concerned about diverticulitis, for example, is probably a CT scan. Colonoscopy is not going to help you too much, and if anything, can potentially actually be harmful.
Yeah.
Does that sort of help you, Nassif? And insofar as I'm aware, we don't have any local guidelines at our hospital. I don't know if anyone's seen anything from the surgeons that may be out there. I haven't seen anything, locally at least.
For us, and we use in Cape Town, I'm not sure if you guys up in Joburg and Durban, you have these VULA referrals. So there's a lot of VULA referrals. It's kind of knee-jerk for them. They admit someone with diverticulitis, no real significant complications other than a few days of antibiotics, and all of them are referred for colonoscopies afterwards. And then just coupled to that, I mean, a sort of practical issue that we have, and Jess, you spoke about the risk, in terms of the risk of, according to the data, it's not an increased risk of damage or perforation. But a practical challenge that we often see, and the challenge often we have sort of the relative open access colonoscopy. We only see the patient for the first time on the day of the colonoscopy. Yeah. So you have sort of sometimes elderly patients, sort of older than 80, referred for colo post-diverticular disease. They have massive diverticular on the CT scan. And now you and when you go in, they have this big sort of pockets of diverticular. Often you sort of don't know what lumen is a diverticular, what's a normal lumen, and always worry that in this patient of sort of older than 80 with other comorbidities, if you do something to this patient or you perforate them, it's a very poor surgical candidate. Patient generally, that's a challenge that we have in terms of almost the appropriateness of colonoscopies in very elderly patients. I do not know, and we don't really have a protocol for that at our hospital. So once again, I'm just keen to hear in that context, how do you guys streamline it at your, at your facility? Thanks.
Okay, so for us at the Jane, we also get a lot of referrals that we're meeting the patient for the first time on the day, and we've been asked to do an elective C-scope for whatever reason. I think you just look at them clinically. So especially in elderly patients, do they look toxic? Have they got a tachycardia? Do they have like severe abdominal tenderness when you're examining them just before the colonoscopy? We always examine our patients before, check their labs before, take a little bit of a history on why we're doing the C-scope. And if that's okay, I think there's, like I said, there's no harm in doing the C-scope because you're very unlikely to perforate a patient with uncomplicated diverticular disease. So just asymptomatic disease or disease that doesn't have inflammation. So either like a SUD, so a symptomatic uncomplicated diverticulitis, or just simple diverticulosis. If you're concerned that there's diverticulitis, clinically, then we wouldn't go ahead with it, but that's quite rare to see. Remember, diverticulitis is only like 4% of patients of diverticular disease in a whole. So I've never had to deal with a patient that's come in acutely toxic looking for an elective C-scope. Yeah, we'd always admit and stabilize first. Yeah.
Yeah, look, I'm really not going to add too much to what you've already said there, but just to remind you all, there is this thing called informed, consent. So if you aren't happy to do a procedure, even within an open access system, for whichever your reason, your clinical indication, the state of the patient, and you're allowed to have that conversation again with the patient. A patient can refuse after adequate, counseling. There's need to say just because I had my 4 liters of clean prep, I'm obliged to have colonoscopy, and you're obliged to actually perform one. If you are unhappy to proceed, you must always think of safety first. And in terms of informed consent, you have to upfront, even before you do a procedure, have a clear indication as to why you're doing procedure X. That goes for any procedure. Because if on that small chance, there's always this, I think if you performed enough colonoscopies, you've had a few of these complications over the years. If there is a complication, the first thing you are asked is, what was the indication for this procedure and why did it have to be performed on that particular day? Could this have waited? Did this patient really need it, etc., etc.? So provided you can answer that upfront, then okay. But otherwise, you're not obliged, even in an open access system, to say yes to everything. Okay. Okay, so I think we're already at 7 o'clock or almost, and I'm sure we've got a long week ahead of us. So I'm just going to say thanks to the presenter and to everybody who participated. Thanks to Echo UNM and the Echo India team for the support. Recordings will be available on the Gastro Foundation website, thanks to the Gastro Foundation. And just to remind everyone, our next presentation is on Monday, the 28th of October at 6 o'clock. So that's actually next week. And the topic is microscopic colitis, ischemic colitis, diversion colitis, and the presenter is Dr. Sean Temmers. I think I know him well. And the chair would be Dr. Neo Siabi. So enjoy your evening. Thank you to the presenter for everything. And I hope everybody has a great week ahead.
Bye.
Bye all.